Good morning, all, and a very happy 75th Independence Day to all. So, I will begin my talk on anatomical and physiological basis of signs and symptoms of peripheral nerve disorders. So, the outline of my topic will be I will be first discussing gross and microscopic anatomy, then something about nerve injury, then anatomy of autonomic nervous system, then sensory and motor symptoms in peripheral neuropathy, and some specific signs in some specific diseases. So, peripheral nervous system consists of a somatic nervous system and autonomic nervous system. Somatic nervous system is further divided into cranial nerves and spinal nerves, while the autonomic nervous system is further can be divided into sympathetic and parasympathetic system. So, first we will focus on spinal nerves. So, in spinal nerves, the spinal nerve is formed by two roots, the dorsal root and the anterior root, which come out of the spinal cord. The dorsal root is a sensory root having its cell body in the dorsal root ganglion, and the anterior root is the motor root. They both combine to form a spinal nerve, and we have 8 pairs of cervical spinal nerves, 12 pairs of thoracic spinal nerves, and 5 pairs each of lumbar and sacral spinal nerves. The spinal nerves then form posterior primary rami, which supply the paravertebral muscles and sensory supply over the vertebra, and anterior primary rami, which combines with other primary rami in the cervical region to form brachial plexus and in the lumbosacral region to form lumbosacral plexus, and then further named nerves and its branches arise from this plexus. So if we transect a spinal nerve, we will see a axon, a myelinated axon, a bundle of myelinated axons. A bundle of myelinated axons is held together by perineurium. So 10-12 bundles of axons are held together by a perineurium, and they are called a fascicle. And these fascicles together form a whole of the nerve, and it is covered by the perineurium. Similarly, so this outer covering, this is epineurium over the nerve. If we cut inside, we will see these fascicles. These are covered by perineurium, and inside the perineurium, these single axons, they are covered by endoneurium. So the dorsal root, which consists of sensory axons, they have a cell bodies in dorsal root ganglions, which is a pseudo unipolar axon. It gives a single process which divides into two. One enters the spinal cord and other goes to the periphery to form the spinal nerve. While in motor root, the cell bodies lie inside the spinal cord called anterior horn cells, and the peripheral processes, they enter the spinal nerve and form motor root. So if we see a myelinated axon, a single Schwann cell cover a portion of a myelinated axon and forms the myelin sheath. While in unmyelinated fibers, a single Schwann cell covers multiple unmyelinated axons. We can see here a single myelinated axon and a Schwann cell has formed a myelin sheath around it. While in unmyelinated axons, a single Schwann cell is supporting many unmyelinated nerve fibers, which is seen microscopically here. This is a myelinated nerve fiber, and this is the Schwann cell covering the myelinated nerve fiber. This is the nucleus of the Schwann cell. And while in unmyelinated nerve fibers, this is the single Schwann cell. It is covering the many unmyelinated axons. So if we see a myelinated fiber, the myelination is not uniform, and at some places it is lacking. These are called nodes. And due to these nodes, the velocity of conduction increases in myelinated nerve fibers to many folds due to saltatory conduction. I will explain this a little bit later. So in myelinated fibers, so these are the nodes where there is no myelin. So action potential travel from one node to another, jumps from one node to another in increasing the velocity of conduction through the myelinated axons. While in unmyelinated fibers, the action potential travels linearly along the course of the nerve fiber, therefore velocity is low. So according to Ellinger-Gassett classification of nerve fibers, the nerve fibers are classified according to their diameter and conduction velocities into 3 groups, A, B, and C. A are further divided into A alpha, A beta, A gamma, and A delta. A alpha are the fastest fibers and thickest fibers. So they have a velocity of around 100 meters per second and diameter of around 15 to 20 micrometers. While C fibers, they are the most thin with least velocity and they are unmyelinated. So as the diameter of the axon increases, the conduction velocity also increases proportionately. Therefore, larger fibers are expected to have larger conduction velocities. Along with the axon diameter, the thickness of myelin is also affects the nerve conduction velocity. The increase in myelin thickness increases the nerve conduction velocity of the nerve fibers. Now again we see a myelinated nerve fiber. The area where there is no myelin, this is called as node, and there is an area around the node where the node is around 1 micron by micrometer in length, and just next to the node there is a paranode where there are uncompacted myelin is present, and along just next to paranode is a juxta paranode, which is a transition zone between uncompacted myelin and compacted myelin. And at the internode, the myelin is fully compacted. So there is a node, then paranode, small juxtaparanode, and then internode area. So in the node region of the myelinated axons, the sodium channels are concentrated so much so that there are around 82,000 sodium channels in a small area of 60 micrometer square area. So this much of sodium channels, they help in depolarization and saltatory conduction from one node to the another. And again, node also contain slow potassium channels which help in the repolarization or hyperpolarization of the nerve fibers. So these sodium channels, they are held in place by ankyrin G, by NF186, neuropathin 186. And contactin associated protein, they hold together the myelin at the paranode with the help of neuropathin 155. And potassium channels are held in place on the axon with the help of Caspr2 antigen, Caspr2 and tag1. The gangliosides here, I have written GM1. The gangliosides, they are present on node and paranodal axolemma, and they help in axon and glia interaction. So in the myelin sheath, this is the axon and the surrounding myelin sheath, there are many proteins which help in the Schwann cell proliferation, myelination, and compaction of myelin. And these are targets of many antibodies, and mutations in these proteins can cause hereditary neuropathies. So if we do a page electrophoresis of myelin, we will find three main bands, which are P0, P1, and P2. The P0 glycoprotein is associated with congenital hypomyelinating neuropathy or CMT1B. The P1 protein, that is also called myelin basic protein, has a role in myelin compaction. The P2 protein is a basic myelin protein, and in experimental allergic neuritis, antibodies are produced against P2 protein. Again, PMP22 and MAG and other proteins, they form proteins and glycolipids, they form minor bands. And PMP22 is helpful in myelin stabilization and also regulates Schwann cell proliferation. Its duplication is associated with CMT, and deletion is found in hereditary neuropathy with pressure pulses. And again, myelin-associated glycoprotein is a cell adhesion molecule, and it helps in the adhesion of the myelin to the axolemma. And antibodies against MAG may be present in paraproteinemias and anti-MAG neuropathies. And antibodies against gangliosides are found in variants of GBS. So what are gangliosides? Gangliosides are glycosphingolipids which contain a ceramide moiety. Then these are sugars which are usually hexose sugars and a sialosyl moiety. So they are named as G ganglioside, M means mono, D means di, T means tri, and Q quadri. These are the number of sialosyl moieties present in the ceramides. In GM, there is only one. M means mono, only one sialosyl moiety is present. D means di, there are two moieties, sialosyl moieties are present. In Q quadri, 4 moieties are present. And B is used to designate the position of the disilosyl moiety in the internal hexose sugar. So these, as I have told, they are present in the gangliosides are present in the node and paranodal axolemma, and antibodies against this are found in many immune-mediated neuropathies. The prominent of which are acute motor axonal neuropathy, a MAN variant of GBS. We can find GM antibodies against GM1, GM1B, GD1A. In Miller-Fisher syndrome, antibodies against GQ1B are found. They are of IgG subtype. In anti-MAG neuropathy, antibodies against MAG is of IgM subtype, and in CIDP, the antibodies against contactin neurofacin are found, and the antibodies against neurofacin and contactin are associated with the severe syndrome and poor response to IVIG. Now, further coming on to the afferent system, anatomy of the afferent system. Afferent system is the job of the afferent system is to convert the various types of stimuli to electrical impulse. So this is done by sensory receptors. So sensory receptors can be mechanoreceptors, thermoreceptors, nociceptors, chemoreceptors, and in this we will discuss more about mechanoreceptors because they are present mainly over our skin and they convert various stimuli into electrical impulses. So for convenience, on structural basis, they can be divided into non-encapsulated and encapsulated receptor. So non-encapsulated receptors are free nerve endings. They are found in our skin. They are associated with pain, touch, hot and cold sensations, and they have unmyelinated. They are unmyelinated and therefore slow to conduct. Then comes Merkel discs. They respond to the touch. They are a type of mechanoreceptor. They respond to touch and they are supplied by A beta fibers. Then hair follicle receptors. They again respond to the touch. They are supplied by A beta fibers. Then comes the encapsulated receptors, which are Meissner's corpuscles and Puxinian corpuscles. So Puxinian corpuscles are associated with the sensation of vibration. They convert the sensation of vibration to electrical impulses, and which then travels to our nerves, to dorsal root ganglia, spinal cord, and to the cortex through thalamus. Now there are two receptors which are although present in muscle, but they are afferent receptors, which are neuromuscular spindles and neurotendinous spindles, also called as Golgi tendon organs. So in neuromuscular spindle, we have intrafusal fibers, which are inside the extrafusal muscle fibers, which are the normal skeletal muscle fibers. In between them is interspersed is these intrafusal fibers. They can be nuclear bag type, which has a central protuberance and narrow at the periphery, and they can be nuclear chain type. So their function is they send continuous impulses, afferent impulses to the spinal cord. In turn, they relay and send impulses to the alpha motor neurons and can lead to the contraction of the extrafusal muscle fibers. They participate in the reflex arc. Then Golgi tendon organ, it is situated over the tendons of the muscle, and it protects the muscle from excessive stretch. When there is excessive stretch, it is activated by the squeeze of the tendons of the extrafusal muscle fibers. When there is excessive stretch, it is relayed to the spinal cord and alpha motor neurons are inhibited so that the muscle is not harmed due to excessive contraction. So coming on to efferent system, these afferents from various receptors travel to the through peripheral nerve to the spinal cord, and then there is efferent system which helps in the movement of the muscles. The basic unit is the motor unit. Motor unit is defined as the alpha motor neuron and all the muscle fibers supplied by it. So basically, when muscles are relaxed, they are not completely relaxed. They are in a state of a little bit contraction known as the muscle tone. It is the passive resistance to the movement of the muscle. So it is the tone of the muscle is maintained by some contraction in the muscle fibers. So in muscles, there is not this thing that muscle will be somewhat contracted and somewhat relaxed. There are some motor units which are firing at a particular time, which are fully contracted. And when they fatigue, the new motor unit takes on. So in this way, the tone is maintained in the muscles. And this is maintained through a simple reflex arc. The neuromuscular spindles and impulses to the spinal cord. The impulses they relate to the alpha motor neurons. The motor neurons then come through the come through the spinal nerve and goes to the muscle and causes contraction of the muscle fibers. So if this muscle arc, this reflex arc is interrupted anywhere, suppose in a neuropathy and afferent fibers are affected and impulses are not carried to the spinal cord, then there will be loss of the muscle tone. The fibers will atrophy, muscle fibers will atrophy, and reflexes, deep tendon reflexes will be lost. So now one again important thing, the axons, they need to interact with their target end organs, which may be muscles or which may be skin or which may be the glands. So, and again, the cell body of the neuron required to send the neurotrophic factors to the axon to maintain the axon. So this is done by axonal transport, which is an active process. It is an ATP driven process. So it has a slow component and fast component. The synaptic vesicles and the components of synaptic vesicles are usually transported through fast component, and neurofilament proteins are transported through slow component. So this axonal transport is undergoes with the help of microtubules and neurofilaments, which form the highway for the transport. And there are molecular motors. These are kinesin and dynactin family of proteins. The kinesin is associated with antegrade transport, and dynein and dynactin are associated with retrograde transport. So they associate with the factors and organelles needed to transport to their respective destinations. So again, something about blood-nerve barrier. The vessels in the nerves, they are not directly communicating with the axons, but there is in between there is pericytes and connective tissue of endoneurium and perineurium. So there is no direct connection between the arteries, capillaries, and the nerves. So this connective tissue in between forms the blood-nerve barrier and is important, because in many inflammatory processes, the blood-nerve barrier is damaged and the inflammatory cells can infiltrate the nerves and damage them. So now a few things about the nerve injury. The Sudden and Sunderland classification of nerve injury classifies it into neuropraxia, axonotmesis, and neurotmesis. In neuropraxia, also called as grade 1 injury, there is only focal segmental demyelination and there is no injury to any other component. So this is a milder form of injury. Recovery is good without any intervention. Then axonotmesis, grade 2 injury. In this, axon is damaged, but endoneurium is intact. The covering around the axon is intact. So the regeneration can occur because endoneurium is intact, and the proximal stump, it regenerates. That I will talk just a few moments later. So grade 1 and grade 2 injury are usually heals by themselves without any intervention. But if there is grade 3 injury, the axon and endoneurium are damaged and perineurium is intact. While in neurotmesis, there is complete nerve transaction and there is separation of the two ends. So grade 5 is the most severe injury and it usually do not heal without any intervention, and we have to oppose the margins. So how after the injury, what are the events which take place? So this is the normal nerve. There is damage to the nerve, and then there is a Wallerian degeneration. The distal stump, distal to the injury, it undergoes degeneration and fragmentation. Macrophages, they engulf the remained portion, and this is called Wallerian degeneration. Then the Schwann cells around the injured segment, they attach to the basal lamina and they form a tube called bands of Buckner. So after bands of Buckner are formed, the axon, they sprout. The proximal axon, they sprout, form Philopedia and Lamellopodia, and they move towards the distal portion, and they are between these Schwann cell tubes called bands of Buckner, and they move at a speed of 1 to 1.5 mm per day, and the regeneration is completed when it connects to the distal segment and there is re-innervation changes. So what are the signs of recovery after nerve injury? So I have already told they grow at 1.5 mm per day. The proximal muscles will recover first because the less is the distance, it will be easily covered by the axon. So proximal muscles are more nearer to the injured stump, they will recover first. Sensory recovery will occur earlier, and this is the pattern of sensory recovery. Pain due to deep pressure will appear first, then superficial cutaneous pain, then heat and cold, and light touch and tactile discrimination are last to recover. And one important sign of recovery is progressive tinel sign. So at the site of injury, if we percuss the nerve, there will be paresthesias along the distribution of the nerve called tinel sign. So when the nerve heals, the tinel sign progressively shift distally because the axonal stump is growing and moving distally. Now a little bit about the anatomy of the nervous system. I will just briefly touch the anatomy and will not take detailed anatomy of sympathetic and parasympathetic system because of time constraint. So in sympathetic system, the preganglionic sympathetic fibers, they are lying in the thoracic and lumbar spinal cord from T1 to L2 segments. Then they come out and they relay in the paravertebral sympathetic ganglia. These ganglia are far away from the end organs. So then through various nerves, they reach to their destination, except the nerve supply, sympathetic nerve supply to blood vessels of intestine do not pass through paravertebral sympathetic ganglia. It goes to prevertebral sympathetic ganglia. In the the neurotransmitter in preganglionic fibers is acetylcholine, which acts on nicotinic receptors on these paravertebral sympathetic ganglia with alpha 3 and beta 4 subunits, and antibodies against these nicotinic receptors lead to autoimmune autonomic neuropathy. And the neurotransmitter in postganglionic fibers is usually norepinephrine, which acts on alpha 1, alpha 2, and beta receptors. So sympathetic system is basically for fight or flight response. So suppose whenever you see suppose you see a lion and you want to run, then your sympathetic system will be activated, and by alpha 1 receptors, the sympathetic system will excite the smooth muscles of the vessel. So suppose you want to fight or flight, you need to have enough blood supply going to your heart and other organs. You need not to have venous pooling in the peripheral vessels. So there is vasoconstriction, which is mediated by the alpha 1 receptors. And internal sphincter is also supplied by alpha 1 receptors. Then beta 1 receptors over the heart, they stimulate SA node, they increase contractility of the heart. And beta 2 receptors, they are associated with smooth muscle relaxation, vasodilation, and bronchodilation. Alpha 2 receptors, they are inhibitory autoreceptors present on presynaptic terminals. Now coming to parasympathetic system, it is also called craniosacral flow. If we observe the parasympathetic system, here the preganglionic fibers are larger and postganglionic fibers are smaller, means ganglions supplying the organs are lying near to the effector organs. And the neurotransmitter here is acetylcholine in all of the preganglionic as well as postganglionic fibers. Now we have the sympathetic and parasympathetic system. They are involved in the beat-to-beat variability, beat-to-weight control of the heart rate and the blood pressure. So there are arterial baroreceptors in the internal carotid artery, which are supplied by glossopharyngeal and vagus nerves. They carry the impulses, and with each beat, the impulses are carried to nucleus of rectus solitarius, which is present in the medulla oblongata here. It is the first relay center for cardiorespiratory reflexes. Then nucleus of rectus solitarius inhibits the cardiac presympathetic neurons in the rostroventral medulla. So rostroventral medulla, this is the ventrolateral medulla. So this contains presympathetic neurons. So nucleus of rectus solitarius inhibit this through caudal medulla. So whenever there is increased arterial baroreceptor discharges, the nucleus of rectus solitarius inhibit the sympathetic output, and the heart rate and blood pressure decreases, in simple words. And again, nucleus of rectus solitarius, they are stimulatory. It is stimulated to nucleus ambiguous, means it is stimulated to parasympathetic system. And when parasympathetic system is stimulated, the bradycardia and decrease in BP occurs. So if there is falling blood pressure, the arterial baroreceptor, what will they do? The afferent impulses to the nucleus rectus solitarius decrease, and the inhibition of sympathetic neurons decrease, and increased sympathetic discharge goes to heart and peripheral vessels, increasing the heart and peripheral resistance, leading to increase in blood pressure. So why this is important? This is important in autonomic neuropathies, where efferent arc or afferent arc of this system can be involved, and we have postural hypotension, orthostatic tachycardia, and other things in autonomic neuropathies. Now about thermoregulation. The peripheral thermoreceptors through peripheral nerve spinal cord gives information to the parabrachial nucleus. The parabrachial nucleus is lying in the upper pons. Parabrachial nucleus in turn projects to the median preoptic area in the hypothalamus. This is the median preoptic area in the hypothalamus, which contains heat sensitive neurons. These neurons are constantly firing and inhibiting the cold sensitive neurons in the dorsomedial nucleus. This is the dorsomedial nucleus of hypothalamus. So heat sensitive neurons, they are inhibiting the cold sensitive neurons continuously. So if from periphery, if we get a response that we are feeling cold, then the inhibition of these heat sensitive neurons will decrease, and dorsomedial nucleus of hypothalamus through nucleus ruffae pallidus causes skin vasoconstriction and thermogenesis. While if we feel heat, if we feel hot, the temperature is hot and humid, the heat sensitive neurons in median preoptic area through sympathetic fibers causes skin vasodilation and sweating. Now coming to the sympathetic and parasympathetic autonomic control of the bladder is supplied by parasympathetic and sympathetic fibers. The sympathetic fibers come from T10 to L1 fibers. It goes to inferior mesenteric plexus and supply the smooth muscle of the bladder and the neck of the bladder, highlighted in the blue. The parasympathetic they supply the smooth muscles of the bladder and the neck of the bladder. So the parasympathetic supply acts by the muscarinic M3 receptors, and activation of parasympathetic nervous system causes contraction of the bladder and passage of the urine. So with M3 receptors, the detrusor muscle is contracted, the urethra is relaxed, and external urethral sphincter is relaxed from external pudendal nerve, and urine is passed. While activation of sympathetic nervous system causes inhibition of bladder contraction by beta 3 receptors, and alpha 1 receptors at the urethra causes the constriction of the internal urethral sphincter. So during resting, when we are storing the urine with the help of Pontine storage center, sympathetic system is more activated and it has relaxed our urinary bladder muscles, smooth muscles, but internal sphincter is contracted due to sympathetic nervous system, and external sphincter is contracted by supply from pudendal nerve. External sphincter is under voluntary control. But when we want to empty the bladder, the parasympathetic nervous system comes into play and there is inhibition of the sympathetic system and we pass the urine. Now this was about the brief anatomy of the somatic and the autonomic nervous system. Now coming to symptoms and signs of neuropathy. So neuropathic symptoms can be sensory and motor. The sensory symptoms can be again divided into positive sensory symptoms and negative sensory symptoms. So positive sensory symptoms are paresthesias. These are the abnormal feeling, tingling, pins and needle senses. So how they occur in neuropathy. So we will try to decipher that. So these are formed by consequence of ectopic discharges generated within the primary sensory units. Remember, these are not generated in the receptors, but in elsewhere along the course of the nerve. So therefore, these are anomalous and they are unusual sensations, in contrast to the predictable and stereotyped patterns of normal sensation. Therefore, they feel abnormal. The basis of ectopic impulse generation is not understood, but proposed mechanisms are: there is activation or facilitation of sodium channels, there is decrease in activation of sodium channels, or there is deviation in function of both the sodium or potassium channel. So basically, there is alteration in the function of the sodium or potassium channels, which either leads to the decreased threshold of activation, and there are ectopic discharges generated along the nerve. So this is depicted in this line diagram. So ectopic, this is the receptor, but the impulse is not generated here, it is generated elsewhere and travels to the spinal cord and the brain, which manifests as paresthesia. Now pain, we have seen many neuropathy patients which feel pain without the presence of noxious stimulation. So that can occur in neuropathy. So why this pain occurs? So many mechanisms are given for this pain in peripheral neuropathy. So one of these is peripheral sensitization. That means then whenever there is some toxin or damage to the peripheral nerve, there are abnormal receptors or ligands which are expressed over the nerve, which lower the threshold of activation of the nerve, and there are ectopic discharges which lead to the pain in the distribution of that nerve. Another mechanism is effective transmission or crosstalk between axons. So these are two axons. There is impulse generation in the one axon, while traveling through the axon, it crosses to the another axon. So this is crosstalk between axons. It should not occur if both are myelinated, but if there is any damage to the myelin due to any pathology, the effective transmission takes place, and it can explain pain in some patients. Now it was seen that even if the peripheral receptors, there is ectopic impulse generation, the dorsal root ganglia and the supraspinal control over the pain can inhibit these ectopic impulses. But with repeated firing, sometimes the dorsal root ganglion, they get sensitized and they transmit these ectopic impulses, which leads to the permanent change in the dorsal root ganglia and permitting the transfer of ectopic impulses to the brain. So this is plasticity within the CNS neurons can lead to the increased pain. Then any defect in the descending inhibitory pathway to the pain by the CNS can also lead to the increased pain sensation. So these were various theories given for increased pain during neuropathy without any noxious stimulation. So after positive sensory symptoms, there are negative sensory symptoms which include sensory loss of small fiber type or large fiber type. So any sensory loss can result from conduction block or axonal loss. The small fiber sensory loss manifests as loss of pain and temperature. And large fiber sensory loss manifests as loss of joint position and vibration sense and touch pressure sense. It can manifest as sensory ataxia from proprioceptive differentiation, and pseudoathetosis can be present. See in this patient, when this closes eyes, there is slow writhing movements of the fingers. This is called pseudoathetosis. This is due to the differentiation, loss of joint position and vibration sense in the lower limbs and upper limbs. So you must have seen some patients of neuropathy which can't stand on a single place. When they stand on a single place, they continuously move their limbs, but while walking, they walk easily. And this thing does not work on the dark. So this gait is to be differentiated from sensory ataxic gait. So this thing, the patient stands on one place with difficulty or has to move his limbs continuously, is due to weakness of both anterolateral lower leg and calf muscles and destabilization at ankles. So the patient feels that he is going to fall, and in that attempt, he moves his feet continuously. While this is not a case in the sensory ataxia. And this thing will not worsen in dark or eye closure, when patient starts walking, this thing will disappear. So this you have to differentiate, although rarely, this is seen rarely. I have seen only one patient who was not able to stand still at one place, but I could not at that time tell what was happening. Now, retrospectively, I can say what it was. Now, a length-dependent polyneuropathy. So, a common variety of neuropathy, we see distal symmetrical polyneuropathy or length-dependent polyneuropathy, also called glove-stocking neuropathy to start with. So, it starts in the feet. The sensory loss starts in the feet, goes to the knees, then starts in the fingers, goes to the elbow, and then if neuropathy further progresses, the anterior abdominal wall is involved because it is involving the longest nerve fibers. So longest nerve fibers are first of the lower limbs. When they are involved, then upper limbs. So these are involved. Then the longest fibers remaining are the fibers supplying the anterior abdominal wall because they come from the back and descend downwards. And after that, sensory loss appears on the scalp, vertex region, and then progresses. And at later stages, normal sensation can be present only over the back and the rest lost. So why this thing occur? Why this thing occurs in length-dependent polyneuropathy? Why it occurs? It occurs because of the dying back phenomena, for which longest axons are most vulnerable. So this is the cell body and this is the axon. So longer is the axon, further it is from the cell body. So for the axon to maintain it, it has to take neurotrophic factors. They goes to the cell body, it processes it and sends back to the axons to use it. So the neurotrophic factors, the axonal transport and the cell body has a role to play in maintaining its axon. So if any process involves the neurotrophic factors, they are not produced, any trauma to the skin or muscle, any toxin which is inhibiting the axonal transport, or any pathology, any pathology which is causing damage to this axon, the most distal portion will die because it is not getting its nutrition from the cell body. So therefore, the most distal axons, they die, and subsequently further axons are recruited in this phenomena. Now comes motor symptoms. First, negative motor symptoms. So weakness is the most common symptom which patient comes to us along with sensory complaints. So paralysis of voluntary movement in neuropathy result from conduction block or from interruption of motor axon. So this is a normal axon. The saltatory conduction is occurring. What happens when there is demyelination? The myelin is lost. The covering over the axon is lost, and there is current leakage, such that when the current reaches the next node where depolarization will occur, it is not sufficient to generate action potential. So current dissipates to the sides in absence of myelin sheath, and it cannot travel further, and this will cause conduction block and weakness of the muscles. While in axonal variants, the axon will degenerate and the conduction will not occur in that portion. So conduction failure will occur. This will cause weakness in the supplied muscle. So when there is a polyneuropathy, the weakness is accompanied by atrophy of the muscles. Atrophy becomes evident within few weeks and progressive because the cell bodies, they are trophic to the muscles also. So when the connection with the muscle is lost, the muscles will atrophy. The permanent muscle fiber loss in denervated muscle begins after 6 to 9 months. So if the regeneration takes place within this time, the muscle can survive. Otherwise, only few fibers remain after 3 years. So now, clinical difference between axonal and demyelinating neuropathy, which is asked since the MBBS days. What is the mechanism for the difference? I will highlight in this slide. So in axonal neuropathy, long axons are affected early, hence initially lower extremities are affected. So axonal neuropathies are usually they are associated with dying back phenomena. Therefore, they affect the longest nerves first. While demyelinating neuropathy, it also, suppose AIDP starts in lower limbs, but it can occur anywhere. Then glove and stocking pattern, again it occurs due to the dying back phenomena. Distal involvement in axonal neuropathy occurs due to dying back phenomena. So distal muscles are involved first, then proximal are involved. While in demyelinating neuropathy, where there is demyelination, that segment will be involved, and proximal as well as distal segment can be, weakness can be there. Ankle jerk is lost early in the axonal neuropathy because of, again, dying back phenomena, while all reflexes are lost early in demyelinating neuropathy because demyelination affects the sensory afferents. It can affect anywhere. So there is reflex lost early. So muscle wasting is common in axonal neuropathy. So because the axons are trophic to the muscles, so in axonal degeneration, the connection between the muscle and the neurons is lost. So muscles, they waste early. While in demyelinating neuropathy, the connection between axon and muscle is preserved. So the trophic factors, they can travel from the nerve to the muscle. So muscle wasting is not common. So recovery is slow in axonal degeneration because the axon will undergo Wallerian degeneration and then axons will regenerate. Then recovery will occur. While in demyelinating neuropathy, Schwann cells rearrange themselves and produce myelin around the axons, and recovery is rapid. Now further coming to areflexia in the peripheral neuropathy. So peripheral neuropathy can affect the afferent arc or the efferent arc of the muscle deep tendon reflex arc. So can lead to areflexia due to these deafferentiation or effector effector axons can be involved. Now coming to positive motor signs and symptoms, which can be observed in peripheral neuropathy. So fasciculations are typically generated in terminal motor axons, but they can arise from anywhere from the cell body to the terminal axons in neuropathy, which may be due to the degeneration, which may be due to the toxins. So what we have to differentiate, sometimes patient comes with benign fasciculations to us. He has observed fasciculation and he is worried. So benign fasciculations are associated with no atrophy, no weakness, and they are usually limited to a specific site. Suppose eyelid, it will remain limited to eyelids and will not generalize. And in benign fasciculation, fasciculation is the most prominent symptom. It is bothersome to the patient, and no other symptoms are usually present. While in pathological fasciculations, it is associated with weakness and or atrophy, can be widespread. The patient comes with other symptoms. He has weakness, he has other symptoms, and on asking, he will say, yes, I have these fasciculations. So although this is not 100%, you can't differentiate 100% using these, but in general, these are the differences. Now, fibrillations are not visible to the naked eye, except in the tongue you can see. Otherwise, you have to do EMG to see these. So myokymia is present in demyelinating disorders of CNS, but in peripheral nervous system, it is seen also in demyelinating neuropathies more than axonal neuropathies, particularly in Guillain-Barré syndrome in around 17 to 20% patients. We look for it. So how a myokymia looks like, see in this video, it's usually a worm-like rippling of the muscles, see around the lower eyelid, and now see around the lip. So undulating worm-like rippling of the muscles. So focal myokymia can be present in radiation plexopathies or chronic radiculopathies. The mechanism of generation of myokymia is transaxonal aphakic excitation. So where there is the lesion, the impulse is formed there, and there is aphakic transmission of the impulse to other neurons, which causes this myokymia. Then muscle cramps are another symptoms which can be present in neuropathy. They are painful contractions of the whole muscle or part of the muscle due to involuntary firing. So we all have observed muscle cramps in some time of our life. They are benign physiological cramps, and they are relieved by forcibly stretching the affected muscles. But pathological cramps, the mechanism behind the origin of pathological cramps is presence of maybe some toxins or dehydration, contraction of extracellular space. Due to these presence of toxins or other non-physiological motor axonal transmission due to contracted extracellular space, there is constant activation of the sensory afferents. The sensory afferents, they constantly fire. The alpha motor neurons, there is persistent inward currents, and alpha motor neurons, they are excited, and there may be aphakic transmission along the axons, which leads to the involuntary contraction of the muscle, leading to cramps. Now, neuromyotonia, these syndromes are characterized by continuous muscle activity, as seen in this video. On feeling, it feels like a bag of worm just below your hand. See once again. These are characterized by continuous muscle activity, can have myokymia, fasciculations, twitching, cramps, delayed muscle relaxation. So initially they were unclassified, but now we know that autoantibodies are present in around 50% of the patients. They are against the Caspr2 and LGI1, and depending upon the symptoms, they are classified into Isaac syndrome or Morvan syndrome. Now, another symptom in neuropathy can be neuropathic tremor. A range of tremors may accompany neuropathy. The tremor is usually caused by co-contraction of bursts of agonist and antagonist muscle. It has a characteristic of enhanced physiological tremor, usually present in upper limb. So, tremor may be a presenting symptom in some typical neuropathies, which are paraproteinemic neuropathy, chronic relapsing demyelinating neuropathy, or variant of HMS1. In these neuropathies, the tremor is usually in the upper limb. Lower limbs are rarely affected, but they can give appearance of orthostatic tremor on standing. So the mechanism for appearance of tremor is proposed mechanism is multiple, but related distortion of sensory input to CNS means the sensory afferents are affected due to these neuropathies. Those sensory input to CNS is disturbed, and there is a mismatch between afferents of spindle and Golgi tendon organs, leading to errors in timing of muscle activity in the CNS and spinal cord. This led to the tremors in these neuropathies. Now, restless leg syndrome can also occur in neuropathies. It is a creeping, crawling sensation which with the urge to move the legs, the patient rises from the bed and paces around to obtain relief. So the mechanism is due to the deficiency dopaminergic dysfunction with loss of supraspinal inhibition and enhanced excitability of propriospinal mechanisms. So why does it occur? Again, the abnormal sensory input from the peripheral nerve damage changes the trigger mechanism and rewiring of dorsal horn. That we talked during the pain, that the dorsal horn is rewired, and there is loss of supraspinal inhibition leading to restless leg syndrome. Again, hemifacial spasm, we all have seen, it is due to aphakic cross activation between adjacent nerve fibers, leading to synkinetic activation of facial muscles. Now, skeletal deformity. Chronic neuropathies develop before cessation of growth period. They give rise to foot, hand, and spinal deformity. I will directly go to the mechanism. So this is the claw hand. It can be seen in acquired neuropathies also. So it is due to the weakness of the intrinsic muscles of the hand, particularly lumbricals. So this is the function of the lumbricals: flexion at metacarpophalangeal joint and extension at interphalangeal joint. While these in neuropathies, these intrinsic muscles are weak and long flexors and long extensors are preserved. So unopposed actions of these muscles will lead to the extension at metacarpophalangeal joint and flexion at the interphalangeal joint, causing claw hands. While claw hand can occur in acquired neuropathies, the claw foot is said, if present in a child with long-standing history, is said to be a marker of a hereditary neuropathy. So how a claw foot is produced? So there is overaction. There is weakness of the intrinsic muscles of the foot. There is fatty infiltration of intrinsic muscles, and these develop contractures along with the overaction of peronei compared to the antagonist. So in these neuropathies, tibialis anterior is weak and it is overpowered by the peroneus longus. So this is the peroneus longus muscle. It comes laterally and then goes over medially to the first metatarsal. So when their peroneus longus is strong, it will contract and the arch of the foot will increase and there will be extension at metatarsal. Along with tibialis posterior, which is strong, there is plantiflexion, there is dorsiflexion of the foot. So foot will be in the position of this thing, plantiflexion at the foot, inverted, along with extension of metatarsal and first toe and clawing of the rest of the toes. Now some specific signs in specific diseases. So in leprosy, especially in borderline, especially in lepromatous leprosy, the sensory distribution is not glove and stocking pattern. There is sparing of the palms and toes till late in the disease, ABC. So why there is this sparing? So as we know, the lepra bacilli, it first goes to the areas where the temperature is less. So if we do a thermography of a patient, the sole areas, they are coolest. In the hand, the soles are the palms are not the coolest. Just proximal to the palm area of forearm and back of the forearm, they are the coolest areas, because thick cuticle of palm and soles, they increase the temperature of bacterial milieu in soles and hands. Therefore, these are spared till late in the disease. Similar thing in leprosy is seen over the face. So in the thermography, these light areas, these are warmer areas and dark areas are the cooler areas. So these cooler areas are involved first. And if you see if there is sensory loss over the face, the sensations will be preserved just beyond the hairline, which was called hairline sign when leprosy was so much prominent, although seen today also rarely. So here the sensation will be lost and below the hair sensation will be preserved. This is because there is increase in temperature up to 3 degrees Celsius under scalp hair. So the bacteria, the lepra bacteria, they will not invade the scalp till late. Again, upper facial weakness, which is very typical of the leprosy. It is due to the damage of the branches which are crossing over the zygoma, because they are superficial and cold. They are involved first. So upper facial weakness is found in leprosy, along with a sign called as buccinator smile. Because buccinator is a deep muscle, the superficial muscles and their nerve supply is involved, and when patients smile, there is these concentric rings, they appear because he can't elevate his angle of the lips. So this is called buccinator smile in leprosy. Now, sparing of large fibers and deep tendon reflexes in leprosy initially, because it is seen that Mycobacteria leprae does not invade swan cells that are actively producing myelin. Therefore, it will invade first swan cells of the unmyelinated axons and involve small fibers initially and later on large fibers. Therefore, there is sparing of deep tendon reflexes in leprosy initially. Now, again, one sign that is not due to neuropathy, but can have presentation like neuropathy. This is pseudo polyneuropathic pattern in spinal cord diseases. What happens in certain demyelinating diseases, due to the lamination of the tracts, the cervical and sural lamina are involved, which can be symmetrical or asymmetrical, and there is pseudo polyneuropathic pattern in these diseases. While in some cervical spondylotic myelopathies also this pattern can be seen, where upper limb pain and temperature is lost and lower limb posterior column sensation is lost. This is due to the lesion near the anterior commissure. Pseudo polyneuropathic pattern can be observed. Now a little bit about the nodopathies. So we have already talked about the node, paranode, and juxtaparanode. There are some diseases which specifically target the nodes. Among them is the Aman and Amsan variants. Antibodies against gangliosides, they target the nodes, and these sodium channels, they are disrupted and they cause the conduction failure. So I will skip this. So in nodopathies, what are the mechanisms by which there can be conduction failure? So due to myelin detachment at the paranode, the current leaks outside and the conduction will not occur further. There can be sodium channel dysfunction. There can be potassium channel dysfunction leading to membrane hyperpolarization. And therefore, these are called nodopathies because they affect only the nodes and paranodes, and they produce picture with conduction blocks. So on NCS, we will see conduction blocks and they will recover rapidly on treatment. But if they are treated on time, they will recover. They will have good prognosis. But if not treated, they can lead to activation of complement and axonal degeneration, and then recovery will be less. Now, last few slides. Now, GBS with selective motor involvement. So, these gangliosides, they are expressed in sensory and motor both fibers. Why there is selective motor involvement in GBS patient in some patients? Because it is differentially expressed in motor and sensory nerves. So motor nerves, they express this epitope more, and antibodies, they are exposed to antibodies, and therefore there is selective motor involvement in GBS in some patients. So we have seen some retained reflexes and brisk reflexes in GBS. What is the mechanism? In this, the inflammation from the spinal roots, it can cross through the arteries to the intramedullary inhibitory interneurons. So interneurons are affected, and it will cause brisk reflexes in GBS. So this was all from my side. Thank you very much.
Thank you, Neeraj. That was a very exhaustive review of peripheral signs and symptoms.
One point I want to say: exhaustive, comprehensive, with good illustration. From where you got all these good illustrations, Neeraj?
I got a very old book of 1980s while searching on the internet, sir.
Yeah, very good diagrams. Very good diagrams. Comprehensive, explanatory diagrams.
Thank you, sir.
I'll request you to unmute yourself, please.
So, due to want of time, we'll go to the next session.
No, Vishnu, you can. There's no time limit. You can take questions.
Okay, okay. So there are two questions. One question is how to differentiate between fasciculations and neuromyotonia clinically.
So clinically, the fasciculations, they will be intermittent. And in neuromyotonia, usually there is continuous movement, and in neuromyotonia, you will feel bag of worms like appearance or feeling when you feel the muscle of the patient, even when the movements are not visible. While in fasciculation, they will come and go, and you will feel some contraction clinically. Although it can be difficult in some patients, but in this way we can differentiate.
EMG can definitely help.
Yes, EMG can definitely help.
So there is some. Somebody has asked for some every session to some quiz at the end of the session that we'll see. Okay, there's only one question now, so let's go to the next session.